us know that mechanical axis is important. We have to restore the knee to the mechanical axis, and there are enough papers there historically to show that in case that doesn't happen, then there is definitely a polyethylene wear, and it does affect the longevity of the joint. It does lead to a poor functional outcome, and we have seen many papers, and I'll quote some as we go on. But this is what we believed till the kinematic guys started, putting their head out and trying to prove a different point. In the last 10 years or so, we've heard about so many alignments now. There's something called as adjusted mechanical alignment, anatomic alignment. There has been something called as restricted kinematic, functional alignment, constitutional alignment. And to me, actually, it gets a little difficult to understand which way to go when there are so many alignments. So therefore, it's better to stick to something which you've done in the past, something which is very clear cut, where you cut the bone, distal femur to 90, proximal tibia to 90, balance the flexion extension gaps appropriately, get the rotation of your femur, and that's it. And this has been shown to work in the hands of our pioneers, Insal, Ranawat, and they've shown 20 years plus survivorship results. Kinematic alignment, and as we heard Dr. Simon speak, every time I hear Simon, there's something different which I pick up. But what I understand is, when we restore the kinematic alignment is get the pre-arthritic alignment and get the native alignment or the constitutional alignment. By cutting the tibia a little in varus, the femoral resection is slightly in valgus, the femoral joint line becomes valgus, and this is how you try and get the pre-arthritic alignment. Whatever papers which have come out for dissatisfaction after TKR, most of the times, these papers who show a dissatisfaction of 5 to 40% dissatisfaction blame alignment as one of the major causes of dissatisfaction. And in my opinion, there are many other causes which can lead to dissatisfaction, where we may have intra-articular causes, extra-articular causes, which are mentioned in this list. And it's not necessarily component alignment which is the main cause of dissatisfaction. And the kinematic guys always try to push this as a major factor for patient dissatisfaction. Talking about adjusted mechanical alignment, what they do here is, they undercorrect the frontal deformity, maintain the femorokinematic alignment, fine-tune the alignment to adjust the tibia to the coronal plane. That means that, the tibia is in varus, but not as much as what the kinematic guys totally propose. Let's see about the advantages of mechanical alignment, and this has been the gold standard. And there are various papers, as you can see, that if the knee is malaligned, it can lead to polyethylene wear. Also, good alignment after TKR helps in faster rehab, and there are many papers for this. Also, this is one of the landmark papers by Merrill Ritter, who showed that if the tibial component is in varus greater than 3 degrees, then the failure rate is 8.7% versus if it is at 90 degrees, then you have failure rate less than 0.8%. The tibial component definitely fails if you cut the tibia in 3-degree varus, and I've seen some of these kinematically aligned knees where the tibia is cut as much as 6, 7, 8 degrees of varus, and I really don't know how these are going to do in the long term. My question is, in kinematic alignment, you try to restore the pre-arthritic alignment, but when we see such kind of knees, how do we know what the pre-arthritic alignment was? How do we know what the native alignment was? How do we know what was the natural tibiofemoral articulation? And then it really becomes difficult to reproduce that. So in India, we see such horrendous knees. Patients do come at the end stage arthritis, and therefore it's not possible to really restore them to the native alignment. The kinematic alignment, now there is some follow-up, but there are no long-term studies comparable to the mechanical alignment guys, and therefore I do feel that kinematic alignment probably is not the way ahead for me. The mechanical axis is definitely a proven technique. It's an all-weather-proof technique, and this is something which is easy for us to reproduce, and you don't need a robo or a navigation to do the kinematic alignment. Even though There are methods, and Simon just showed you some methods where without a robo also you can get a kinematically aligned knee, but I think it's difficult and it may not be reproducible in everybody's hands, as opposed to a mechanically aligned knee, which is quite easily reproducible with the jigs. Which way to go? It's really confusing. Kinematic alignment is gaining some popularity. I think there is some merit in that. That once you reduce the soft tissue dissection, and you are able to know what the native alignment is, and then you can have your tools, may it be jigs, may it be robot, whatever, and try and get that. And the reduced soft tissue dissection, I think, does help for early recovery. I see some benefit there, but otherwise, I think for me, mechanical alignment is the way to go, and this is the gold standard. One can think of doing adjusted mechanical alignments. For me, what has changed ever since I've been studying kinematically aligned concept is, my soft tissue dissection has reduced. If it's a severe varus deformity, I would rather, put the component in slight varus and reduce my dissection on the medial and the posterior corner. Otherwise, the dissection used to be so much to get those knees aligned. So that has changed. Definitely, for even valgus knees, my dissection is not so much, and I'm, slightly not worrying to cheat on an increased cut, and that is what I am following. But for me, still the mechanical axis remains the gold standard, and I think that is the way to go ahead, unless Simon and the other folks really convince me to do otherwise. With this, I thank